for today's CATH conference. We really do have a special guest before I introduce him, I want to introduce my co-moderator. You know, one of the nice things about this course is it really has become really international, Goran. So today to help co-moderate with me is Dr. Kader, Aisha Kader, who is joining us from Dhaka. And Aisha, like many other of us in cardiology, you know, had, I think, her fellowship affected, her potential to do a fellowship at least, affected by COVID. And so I'm really glad you join us, Aisha, because you're exactly the kind of person we're trying to reach with these CATH conferences. It was really started to try and help our fellows and other fellows. So thanks a lot for joining us. Okay.
Thank you so much for having me today.
Pleasure. And so today we have a really good friend, Dr. Goran Stankovic. For those of you who don't know Goran, most people know him. He's very well published. Me and Goran were lucky enough to do our fellowship in Milan in the same center. Goran, I saw there's even Steve Goldberg who joined us today. So there are a few of us ex-Milano fellows on the call. Antonio also joins sometimes when he's able to, because he likes these CATH conferences. So don't be surprised if at the end you hear his voice too. Goran is really someone I enjoy listening to about bifurcations. He's very balanced. He has a lot of experience. And he's also the president of the European Bifurcation Club, which I think has been, for me, probably one of the most influential organizations in bifurcations and left main to really try and make sure we have data and evidence on which to base our decisions. They come out really with recommendations published in Eurointervention. And I suggest for all the fellows to really every year look out for the EBC recommendations. A lot of thought goes into those recommendations. They're based on data, and when there's no data, they're based on consensus that happens during the European Bifurcation Club meeting that's once a year. I would also suggest for fellows who are in Europe, you know, really, if you have the ability, once we are able to travel again and meetings open up, this is a meeting you'll really enjoy if you like bifurcations. Goran, thank you so much for joining us from Serbia today. We're looking forward to listening to you.
Thank you very much, Azim, for very kind words. Thank you, of course, for kind invitation to participate in your fellows conferences. My task is tips and tricks in bifurcation PCI. And as you said, I work in Clinical Center of Serbia in Belgrade, but I finished my fellowship 3 years with Dr. Antonio Colombo in 2000 to 2003. I have difficulty to move the slide.
You have to literally move your mouse on the screen, in the center of the screen, and then click. Oops.
Oops.
That's okay. You can get it again. There you go.
So I don't have a conflict of interest to disclose, but as you said, I'm one of the founding members and current president of the European Bifurcation Club. So my talk is strongly influenced by our discussion and, as you said, by all published consensus papers. Why bifurcations are so important? Bifurcation PCI accounts for approximately 15 to 20% of everyday PCI work, but there is really variation in anatomy and dynamic changes during the treatment. So we need to have individualized approach because no two bifurcations are identical and have one of the highest complications peri-procedural as well as long-term follow-up rates. So for that reason, we created in 2004 European Bifurcation Club, and you may see the founding members, Yves Louvard, Thierry Lefebvre, Olivier Darmon, Raymond Biero, Manuel Pan, and I'm sitting here next to Olivier. So I was the youngest one and they cut me from this initial picture and I really feel very sorry about that. So the last meeting, we have yearly meetings. The last meeting was in Barcelona during the demonstrations last year in October. So I will try to share with you some of the discussion during that conference. We are very proud to have representatives worldwide. We had 183 invited delegates from 44 different countries. And we are very proud that we cooperate with all other bifurcation clubs worldwide, Chinese, Asian, Korean, Canadian, Tunisian, Japanese, Egyptian, Latin America, India, Bulgaria, and we hope that from this year we will start to work very closely with Sky, because we believe that there is a lot to exchange and there is a lot to learn from Sky, but also a lot to share with you. So main topics this year at TBC meeting were to define for the first time in the full session format which side branch is clinically relevant. When we started in 2005, the main question was what is a significant side branch, and our decision was to define a side branch that you don't want to lose. But in these 15 years, we really came to Bifurcation Academic Research Consortium, BIF-ARC, led by Yves Louvard and Patrick Serrouilles. And we said that identification of clinically relevant side branch should be the first step when planning bifurcation PCI. Because we learned from Hashamovic that only myocardium, which is more than 10% of myocardial mass, is clinically relevant, and we try to define side branches which actually can cause more than 10% of myocardial ischemia. And there is nice CT work from Korea in which we learn that, of course, all left main bifurcations are supplying more than 10% of myocardial mass. But if we look all non-left main bifurcations, you see it was surprising that only 20% of all other non-left main bifurcations actually supply more than 10% of myocardium. So this is one possible explanation why we failed in so many studies comparing one versus two-stent strategy. Because if you think of treating in your study, bifurcation which does not supply clinically relevant myocardial mass, then actually you can only risk procedural complications and you cannot have clinical benefit. We can try to identify angiographically clinically relevant side branches, and Bong-Fong-Koo recommended SNOOC and modified SNOOC score, which are based on LAD and diagonals, telling us that vessel diameter, number of diagonals, and position of diagonal is relevant in order to approximate which one supplies more than 10% of myocardium. But more precise way to understand which side branch supplies 10% of myocardium can be received from information from CT. And this is another important publication by Kim, which tells us that side branches with a length more than 73 millimeters on the average were most likely to supply at least 10% of fractional myocardial mass. So the goal of European Bifurcation Club is to try to identify, to recognize clinically significant side branch, and then create new definition of coronary bifurcation, having major and minor bifurcation. If bifurcation does not supply more than 10%, that will be stratified as minor bifurcation, and we could recommend for those branches guide wire protection and keep it open strategy. However, if we have major bifurcation, then we need to achieve optimal side branch result, whether we are using provisional or two-stent technique. Last year, we also recommended to the participants new MEDS classification. MEDS classification is classification of the stenting techniques, which is based on the position of the first implanted stent, which could be implanted in the main vessel proximal, main across the side, which is classical provisional, then distal or the side branch first. And in this new classification, we removed some of the anecdotal strategies, but we also added some important steps, and we put P, S, and K for pot, side, and kissing, and you can see that now you can use this classification to describe the whole procedure. You start by stenting across, then you perform pot, side branch dilatation, and second pot, or pot, kissing balloon inflation, and final pot. And if you need second stent in this strategy could be done by either T, tap, or the culotte technique. And there is, of course, inverted, which means you can stent provisionally from the main vessel into the side branch. So bifurcation PCI in 2020 is actually recommended as a standard stenting approach for majority of bifurcations. We have it in the most recent guidelines of the European Society of Cardiology, and it was based on multiple randomized trials. At least 11 randomized trials show that there is no advantage in using systematic two-stent strategy, and stepwise provisional T should be a gold standard for most. Of course, there are occasions when two-stent strategy upfront is needed. From those trials, we learned that procedural time and fluoroscopy time and usage of contrast is significantly lower with provisional compared to all two-stent techniques. However, the rate of final kissing balloon inflation is lower in provisional compared to two-stent techniques. Procedural success in those studies was similar, and there was slightly higher rate of MACE in BBC1 study, which compared predominantly culotte with provisional by Dr. David Hildig-Smith. What is for us even more important is to understand that term of follow-up is very important, especially long-term follow-up after 5 or 10 years, because what we see in publication of individual patient data pool analysis of the Nordic and BBC1 is that after 3 years of follow-up, we see that two curves diverge, and we have at 5 years of follow-up significantly higher rate of all-cause mortality in two-stent strategy compared to one-stent, which is probably also related to first generation of drug-eluting stents used in this study. But then when Nordic people reported 10 years of follow-up of the Nordic one, we see that even at 10 years of follow-up, there is continuous divergence in two curves, with less metal or provisional having lower rate of all-cause mortality at very long-term follow-up. There is important meta-analysis that I want to present. It's 9 randomized trials with 3,265 patients published by Ford in 2018. Mean follow-up is 3.1 years, and less than 1% of patients were lost to follow-up. The primary outcome of this meta-analysis was all-cause mortality, and secondary outcomes, MI, definite or probable stent thrombosis, TLR, and MACE. So what is important to understand is that when we put all the studies, including DK Crash 2, DK Crash 5, at 3 years of follow-up, primary outcome all-cause mortality was significantly lower with less metal, with provisional compared to two-stent techniques. There is 31% relative risk reduction, but there was no reduction or difference in any of the secondary endpoints, MACE, MI, TLR, or stent thrombosis. And 5 of those studies with 1,713 patients reported 4.7 years of follow-up, actually 5 years of follow-up, and difference in mortality was maintained, was even higher with 37% relative risk reduction. So how to perform provisional according to EBC? These are the main principles, which are, as you said, based also on data that we acquired. So we believe when we treat bifurcation, we should try to do it simple and safe, to try to limit, if possible, number of stents, respect the original bifurcation anatomy, which is fractal, and to try to reproduce it with a tubular stent, aim for well-opposed, well-expanded stents with minimal possible overlap, and the elective treatment of bifurcations with complex anatomy and diffuse atherosclerotic involvement of both branches, main vessel and the side branch, usually requires upfront planned two-stent strategy. EBC encourages operator to keep things simple even in that case when we elect for two-stent strategy. But when two-stent strategy is used, this should be done in a provisional stepwise approach, finalizing the procedure using T-tap or culotte technique, and for operators with appropriate experience, double kissing crush is a valuable option for complex left main bifurcation lesions. These are the steps of provisional, and I will go through all of these steps. So we should start by wiring both branches, and we think it's very important to use jail wire. we should predilate main vessel in order to have optimal main vessel stent expansion. Of course, in the beginning, we do not recommend routine predilatation of the side branch as well, but it's left to operator decision. And if it's very tight, diffusely diseased, especially if it's calcified, please predilate side branch as well. And then very important stent selection step. So we believe that stents should be selected according to distal reference diameter. Why is that? Because if we select according to distal main vessel, then we have known under expansion in the proximal, but we will reduce carina and plaque shift. So we will not compromise side branch ostium. If we select stent according to proximal main vessel diameter, of course, it's too large for the distal main vessel, which significantly decreases in a stepwise manner. So if you have bifurcation origin here, then you have step down in diameter from proximal to distal. There is no linear tapering, and that's something that really changed the way we do procedures. In order to know how to select stent, you need to read the articles showing stent expansion capacity. One that I really recommend is one from Nicolas Foin group, published in International Journal Cardiology 2016. And after selecting and implanting stent according to distal reference, next step is a key step of Bifurcation PCI, proximal optimization technique. Why proximal optimization technique is so important? You see that if you have stent selected according to distal, then your wire can go really behind and outside of the stent, and we documented that with OCT images. So what is important to understand is that after implanting stent, we need to select adequately sized one-to-one short non-compliant balloon and post-dilate proximal part of the stent in the proximal main vessel, and this will recreate natural fractal geometry. So we will have one tubular stent with two different diameters, one larger proximally and one smaller distally. So you can see in the visible heart model that post-dilatation, this is direct angioscopy visualization in the swine heart. And after stenting of the main vessel, you will see that after adequate proximal optimization, you will have full apposition of the stent struts in the proximal part of the main vessel. So now you can see smaller diameter distally, larger proximally, and you can see it also on the OCT images. Should we use always non-compliant? No, we can use both compliant and non-compliant balloon for pot, as long as we make sure that balloon stays inside the stent. Kissing is in provisional optional step, it's mandatory, and there is also another option to do pot kiss pot. If we do kissing, we should use short non-compliant balloons sized according to distal reference of the side branch and the main vessel. We should start by inflating side branch first, and then main vessel, and then simultaneously deflate. It's very important to have longer inflation, if possible 20 to 30 seconds, but 2 or 3 inflations of 10 seconds will do the same. By performing final kissing, we are actually removing struts, and we try to reestablish natural flow pattern with high shear stress at the carina level and low shear stress in the lateral walls. Pot side pot is alternative, which is now tested in clinical trials. And what is important also is that after performing kissing, especially with longer proximal overlap, we have so-called bottleneck effect. So we need to do final pot at the proximal edge of the stent in order to correct elliptical deformation and in order to oppose stent throughout its proximal length. What we still discuss is exact position of the balloon, because in 4 different publications, you can see that there is no agreement, and sometimes balloon is more proximal or more distal. Our goal is to position pot balloon proximal to carina. Here is, if you follow the steps, micro CT 3D fly through. You see that now we fly through the proximal part of the main vessel. We see widely open access to the side branch, and then step down in diameter in the distal segment of the main vessel stent. So if we need second stent, we can do it in a T, tap, or culotte fashion. And it's very important to understand that our goal is to try to cross through the distal cell. Of course, we cannot always achieve it. Of course, sometimes we go proximal, sometimes we go centrally, but our goal should be, if possible, to cross distally, because by crossing distally, we are able to push some metal from the stent and scaffold and support the ostium of the side branch, and we will have less protrusion of the stent in the side branch if necessary. If we cross proximal, then probably we will not so nicely scaffold the ostium, and we need to pull back stent from the side branch inside the main vessel and create metallic neocarina, and this procedure is named T and small protrusion or TAP. Here is the micro CT evaluation with main difference between TAP and T, and you see in T stenting, you don't protrude inside the main vessel stent. In TAP, you protrude, and we don't have at the moment data which show detrimental effect of TAP. If we speak about one two-stent technique that is the most forgiving for all bifurcation angle, it's probably the TAP. So if you want to learn at least one two-stent technique, I think my recommendation to all your fellows is to learn TAP. You will see now fly through in both T and TAP, and you will see the main difference. So in T stenting, you don't have protruding struts inside. In TAP, you have usually minimal protrusion of the struts. So this is the difference between most probably recrossing point if we aim to cross distal cell. And geographically, it's very difficult to say which cell is proximal or distal. For example, after main vessel stenting, you have wire crossing to the circ, and angiographically, it's very difficult to say it's proximal or it's distal. In that case, you can do imaging, and you can sometimes get surprised, because in this case, as you see, you are not proximal or distal, you are completely outside, because your stent is not post-dilated and well opposed in the proximal part. When we speak about elective two-stent techniques, this is the algorithm of the European Bifurcation Club. In bifurcated lesions with extensive atherosclerotic involvement of both main branch and important side branch, we should approximate the risk of losing the side branch after main branch stenting. And if we consider that there is a low risk of losing the side branch, we recommend as a routine procedure standard provisional. However, if we have major concern regarding the side branch after main vessel stenting, and that fear from losing the side branch is actually the major drive for upfront two-stent strategy in most of the cath labs, and we try to discuss with people and share the data and experience. We believe if you have major concern of losing probably dominant side branch, then you can either do decay crush if you have experience, or you can do also inverted provisional. You stent from the left main into the circ, you do pot, distal wiring, dilate, and then you can do inverted culotte, inverted T or TAP. Depends how much you pull back your LAD stent inside the left main. So you can do provisional, you can do decay crush, and you can do also inverted provisional. Left main is different because it has specific anatomical characteristics like T-shape angulation. It's 80 degrees on the average, while all other bifurcations are around 50 to 60 degrees. It's a large main vessel because it originates directly from the aorta, and there is huge discrepancy in caliber between proximal and distal part of the main vessel. It's frequently calcified. Ostium of the left main could be involved. Side branch is not small, it's usually circumflex, and trifurcations occur in about 10% of cases. What we learned from contemporary CT atlas of Dr. John Ormiston group, that left main stent caliber is between 4 and 6 millimeters, In 10% of cases, we have trifurcation. But if we select stent according to ostial LAD diameter, size of the distal vessel, see in the cross-sectional area how grossly underexpanded stent you have inside the left main. So you need to do proximal optimization before rewiring, and you need to oppose appropriately that stent proximally before exchanging wire towards the circ. So what is the impact on stenting technique of those anatomical characteristics? Because of caliber discrepancy, pot is the essential, and you need to consider stent design because you need to open 3.5 up to 5, sometimes 5.5. Then wide bifurcation angle has impact on technique selection. Aorto-ostial involvement is important because there is a lot of elastic tissue with recoil at the ostium. And there is, of course, direct contact between the guiding catheter and the stent. So there is a risk of longitudinal stent shortening. And in case of calcification, lesion preparation is the key. So I will just touch some specific technical considerations and the importance of left main caliber discrepancy. Actually, I would like to share with you one of the most frequent questions at all bifurcation courses. Should we exchange wires before or after pot? This is the final result of adequately performed procedure. You see angiographically looks beautiful. And then if you do IVUS, this is left main coming. And look here, wire was crossed into the circ outside and you completely push the stent. So you have double lumen with compression of stent inside the left main that is impossible to visualize unless you do imaging. You see fantastic angiographic result at the end of procedure, and then at routine 6-month CT follow-up, you see stent longitudinal deformation and compression, which is actually caused by the contact with the guiding catheter. Longitudinal stent deformation in the XL is more than 6% and is correlating with long-term mortality. It's very important to understand in this cartoon that accidental intubation of the guiding catheter is usually caused by device withdrawal, IVUS, balloon, or by jailed wire pullback. So be careful, work with your left hand, disengage guiding catheter, and wait until all balloons fully deflate. And there is a risk of side branch occlusion, of course, and side branch is not small, side branch is circumflex. So the last option is to perform side branch salvage technique, and you can use your jailed wire in red, and you can go with balloon on a jailed wire, small balloon 1 or 1.5 millimeter, which can go under because of the difference in diameters between proximal main vessel and distal left main and distal main vessel, which is LAD. And by passing a balloon and small inflation, you can reestablish flow, visualize circ. So don't be afraid of jailing wire. Jail wire can help you in case of side branch occlusion. What data we have for the left main? Of course, opinion of the club is provisional is also good option for most of the left main cases, but European guidelines are recommending true bifurcations of the left main. A double kissing crush may be preferred over provisional with the class of recommendation 2B and level of evidence B. There is one study, DK crush 5, in which target lesion failure was significantly higher in yellow with provisional compared to red with DK crush up front. But we need to carefully analyze characteristics of patients in order to learn and to improve our strategy. Because if you see those data for QCA, side branch, circumflex lesion length, 16.6, 16.2. So it's really very complex lesion subset that was selected for DK crush 5. And since the Benesten study, we know that if we have lesion which is 17 millimeter long, that stent is better than balloon. So if I want to be challenging you, I can say that 47% crossover stent, crossover rate in pre-dilatation provisional is, for my opinion, low, because with such diffuse disease of the circ, you probably need higher rate of stenting of the circ if you want to be compatible with upfront decay crash study. Very important information comes from sub-analysis. According to definition criteria, if you compare population with simple characteristics compared to complex, there is only positive effect of two-stent strategy in complex. So this is what we know now. We have data. If we have really complex lesion, two stents are better. And I think we need just confirmation in other studies than decay crash that this is true. So far, we have results from the Excel. In Excel, 3-year adverse outcomes were worse with two stents compared to provisional, like in every other bifurcation. And if you see that MI and stroke rates up to 3 years was higher with two stents compared to provisional. And even if you add ischemia-driven revascularization, there is a strong trend for a difference. So more metal is worse, like in every other bifurcation. And similar in the Nobel as one or another most contemporary left main study. So there is currently ongoing EBC main, European Bifurcation Club left main coronary study, randomized comparison of single versus planned dual stenting for true left main bifurcation lesions. And we also compare single stent as initial strategy compared to upfront two-stent strategy according to operator preference. And in that study, recruitment is finally completed on December 1st last year. So we are eagerly awaiting the results. It's again similar to decay crash, 12-month target lesion failure event. So dear colleagues, it's my pleasure to conclude this introductory talk by saying that provisional side branch stenting is recommended for majority of bifurcations, including the left main, because it preserves my options. Stent technique should depend on individual patients' anatomical characteristics and the operator's skill. Elective two-stent strategies may be considered for important side branches with complex, extensive stenosis, difficult side branch access, or high risk of side branch compromise. And among two-stent techniques, there is a strong randomized evidence for decay crash, while EBC main results are awaited. I thank you very much for your attention. Next meeting of the EBC is scheduled for October 23rd, 24, but we are still discussing, and I think like all the other big meetings, we will also follow, and we will do it probably partially virtual. Thank you very much for your attention.
Excellent, Goran. Thank you so much. That was very thorough. It's nice to see also how the Bifurcations Club's strategies have changed over time and adapted to the literature. Before passing it to Aisha, so we can do the questions from the fellows, our mentor, Antonio, is on, and I always like to give him a little word when it comes to bifurcations before we go to the questions. Antonio.
But can you hear me? Yes, I think
yes.
so. Goran, was a great talk.
Thank you.
It's always hard to listen to talks about bifurcations because, you know, the story is always the same. I believe time of randomized trial provisional versus two-stent is finished because there is no reason to use two stents when you can use one. Nevertheless, we have to explore other solutions instead of placing two stents. Because I tell you, many times when you place two stents, the long-term results are not so good. Because especially in the left main. So now we have better strategies, drug-coated balloons, better lesion preparation, pressure wire to evaluate the result, IVUS. So even in complex bifurcations, we may have to limit the stent on the side branch, if possible, by using imaging to define optimal result, to prepare the lesion better, and to evaluate a drug-coated balloon. This is all work in progress. Nothing to say should part of the clinical practice, but I believe it's time to explore new ways to treat bifurcations.
Yeah, I thank you very much, Dr. Colombo. As always, we discussed every step in the development of the club and bifurcation strategy. You will be again one of the leaders, hopefully in the next meeting. We were waiting for you last year. As you remember, we wanted, yeah, because of the strike in Barcelona, you couldn't come. But I can share with you that European bifurcation will start soon. Exactly what you said, study with drug-coated balloon for the side branch. And for all those who are interested, please send me email and I can pass to committee, which is preparing study design.
Great. Thanks, Goran. I'm going to pass it on to Aisha Kader, who's going to ask some questions and pose the questions from the other fellows in the chat to you, Goran.
Thank you.
Aisha.
Thank you, Dr. Latif. Thanks so much for the opportunity to co-moderate with you as well. So I do have a couple of questions which I'll ask before moving on to questions on the chat. You did mention that provisional was the way to go, but in the event of a systematic two-stent strategy, what factors would you consider when you choose either a main branch first or a side branch first two-stent strategy?
Okay, that's an excellent question. So amount of plaque and plaque distribution, as well as the angulation, are predominant factors that we need to take into account in order to have individualized. So what we have so far from published evidence is that we should try to determine which lesion is more severe, and probably if we already select upfront two-stent strategy, we should start by stenting towards the more severe lesion. If it's ostial circ, which is large vessel, diffusely diseased, then we should stent like inverted provisional from the left main into the side branch, and then do T-tap or culotte towards the LAD. But if DK crush is your preferred option, it's also fine. You can start stenting circumflex as the main vessel and LAD as the side branch that you will stent first with DK crush. So we are trying not to be dogmatic and open for exchange of experience. And our personal strategy is that we should try to first decide, based on our experience, what is the estimated risk of compromising side branch after stenting of the main vessel. And in that one, I completely agree with Dr. Colombo. And this, of course, requires experience. But experience is the only thing that you cannot transfer to your fellows. Everyone needs to practice and gain the experience. So this is why courses like this one and the exchange of experience are very relevant.
Thank you. Another question, in an acute case, for example, in STEMI, if we open up, say, an occluded LAD and then find that a very large diagonal is significantly diseased from its osteoproximal, what strategy would you recommend? A single stent only, given that it's STEMI, quick in and out, or would you go for a two-stent strategy in that case?
Yeah. So there are also very limited publications related to acute setting and bifurcation lesions. Most of those find as a result that the simple as possible solution always work better. So if you are able to stent the main vessel and to reestablish the flow, this is what you need to reestablish the flow, not to optimize result of the diagonal. But if you have less than 50% diameter stenosis in diagonal with STEMI flow, you can leave it at that stage. So it's not quick in and out, but it's to achieve result which is acceptable for both main vessel and the side branch. If you need, even after kissing, if you are not able to achieve good result in the side branch, of course, you need to proceed to second stent. And in that case, as I said, we start by stenting main vessel first, and then we can do T, tap, or culotte. It's your choice.
Thank you. Extending on that, there's a question from the chat for if there's any role of physiologic assessment, for example, FFR, in deciding on side branch intervention.
What we have so far is that after stenting of the main vessel, functional evaluation can be used to determine significance of the side branch. But what we learn in our practice is that it's rarely the case. And if flow is not adequate, we should open struts and we should perform kissing, because by performing kissing balloon dilatation, according to one of the FFR studies, we are able to reduce in 30% of the cases back to normal compromised flow in the side branch. So our strategy is, if we are in doubt, of course we can proceed, and that's the only clear use and indication for physiology evaluation in the side branch, that after stenting of the main vessel, we can check significance by FFR. If we want to proceed without FFR, then we need to open struts and do kissing, because we will have another 30% of patients in the safe area with physiologically normal flow.
Thank you. Again, another question on side branch and wiring. The keep it open strategy. What wire do you recommend, hydrophilic, or what sort of wire would you recommend to keep a side branch open? And what about pre-dilatation proximally to help in side branch wiring? When would you do that?
Yeah, so for bifurcation PCI, in almost all cases, you use your workhorse wire. Sometimes it's BMW, sometimes it's run through, or your choice. We don't routinely recommend, and we don't use hydrophilic wires as a workhorse wire. But if you have difficulty crossing, the second step after regular wire is hydrophilic wire, and then the third step is a stiff wire.
Also some questions from the chat on DK crush. For new attendings, what would you recommend? Go ahead with a proctor or deep dive into it? And also another question about whether the worst outcomes with the two-stent strategy on Noble and Excel is due to the use of techniques other than DK crush. DK crush is clearly superior for left main bifurcation. So your thoughts on that, please.
Thank you for that question. It's not simple to answer because DK crush has 9 steps, and you can make mistake at any of the 9 steps. And if you see visible hard demonstration of DK crush from inside, it's really very challenging to perform all the steps if you are not experienced enough. So I believe, and I agree with your suggestion, to start with someone who is experienced, who can help you first in the bench testing to go through all these steps. And when you learn how to perform it, then you again work with the tutor in the cat lab. After you gain the experience, from that point, I can agree with you, it's safe and predictable stenting technique for complex bifurcation lesions. In my opinion, and I have to say that it's in my opinion, I don't like to stent side branch first in case that is not really complex, like the complexity of DK crush 5. Because we performed EBC2, European Bifurcation Club 2 study, and we compared culotte with provisional in complex anatomy in significantly diseased side branches, more than 10 millimeter disease in vessels which are more than 2.5. And we did not find any difference between provisional extending to second stent T or TAP when necessary compared to upfront culotte. So I believe you need to select one technique like T or TAP for wide angle bifurcation and practice and perfectionize that one. And then another one like either culotte or DK crush for more narrow angle. And then again, practice that one. Because you need to be really familiar at every point of the procedure with the next and the step after the next. Unless you really understand from 3D perspective all the steps, I don't recommend to go to complex strategy before starting with provisional and then adding second stent like T or TAP.
Yeah, Goran, I just make a comment on that to reiterate that. I like DK crush. Both of us learned crush from Dr. Colombo. But I've become very concerned recently when I see people perform DK crush, and I see some of the cases presented at meetings, because clearly people use the terminology DK crush differently, and it's not, they don't always follow all the steps, yet they call it a DK crush. And it's very easy to mess up the steps. You know, and one of the things I teach my fellows is something that Antonio always taught me, was that when you decide to put 2 stents in a bifurcation with a technique like DK crush or culotte, you take on a responsibility, okay? And your responsibility is that you really have to have an excellent final result. It's, you know, with provisional might be more forgiving, but when you take on a 2-stent technique, you take on more responsibility. And all what matters is really the final result. And I think, you know, imaging then and doing, whether, you know, it's IVUS or OCT in those kind of bifurcations is very important.
Yeah, I fully agree. I fully agree, Azim, with you. And in my perspective as well, I've seen on different meetings worldwide really terrible complications and mistakes. And most of them actually occur during complex stenting strategy. It's not just DK crush. There are multiple innovations, but also indications for starting up with planned 2-stent strategy. I remember there was a live case, I think at Asia PCR last year, that patient had isolated LAD osteal disease, and procedure was DK crush. So for me, it was really very difficult to understand that if you have 0-1-0, DK crush is your standard practice for that kind of bifurcation. And that's why I also like to hear the opinion of Dr. Colombo, if he is willing to comment.
Yeah, I think he has a comment.
I have a comment. I think to answer the question that was asked before, I would say that there is no preferred strategy for 2-stent technique. People should learn 3 strategy, crush, 4 strategy, crush, DK crush, culotte, and tap. And they should apply these 4 strategies in different situations. If you have a patient with acute MI or suboccluded LAD and circumflex, and you have to act quickly, you use old-fashioned crush. You place 2 stents immediately, and you open the vessels and establish flow in both sides. You don't mess around with DK crush. If you have an angulation which is 90 degrees or close to 90 degrees, you go for tap. It's such a simple, elegant technique when the angle is close to 90. In some situations, you use culotte, and in other situations, you use DK crush. So you have different tools. I don't like these studies that compare one technique versus the other. It's not such a thing like that. You have to use the technique tailored to the specific clinical setting and anatomy. Even clinical setting, if you have to move quickly and the patient is unstable, or patient is an elderly patient that cannot stay on the table more than 30 minutes, you don't embark in DK crush.
Absolutely.
Absolutely. Thanks, Antonio. Aisha, I'll let you continue. I see there are a lot of questions from
Yes, lots of questions on distal left main bifurcation and the osteal circumflex. What is the role, would you think, of IVUS in assessing the strategy when there's an osteal circumflex lesion? And if you would kissing balloon in KBI to open up the circumflex routinely in distal left main bifurcation?
Yeah, osteal circ is, I think, the last lesion subset that we don't have definite answer. What is the best approach? I can share what is my personal opinion, and I did 2 live cases in Toulouse for the PCR live in a box. I believe that imaging is extremely important in order to understand amount and distribution of plaque, as well as the vessel size of the circ, in order to select maximum possible stent diameter. And then I stent crossover from the left main into the circ. I perform low to moderate pressure deployment. According to bench, you can go to 6 or 8 atmospheres to achieve adequate diameter of the distal segment of that stent, and then post-dilate proximal part with adequately sized balloon for the left main, and circumflex with adequately sized non-compliant balloon for the circumflex. So my goal is to select the largest possible nominal diameter of the stent and then do adequate post-dilatation with non-compliant balloons separately for circ, separately for left main. If left main is not diseased, I try not to cover always, depends on the length, up to the ostium of the left main. But what is important whenever you do such procedure, the length of the stent inside the left main should be at least 8 or 10 millimeters. Depends on the shortest available non-compliant balloon that you have in order to perform stent optimization. If you perform adequate post-dilatation, in that case, you can continue with kissing. It's a personal preference because we don't have data demonstrating clinical benefit of kissing in provisional. If we have diffuse disease, which is maybe non-significant, but there is by iris existing plaque also in the left main, in that case, I think it's planned up from two-stent strategy, and then again, it's your choice.
Thank you. That answers a lot of distal left main questions on the chat. There's another question of approach to circumflex osteal restenosis after bifurcation stenting. What would be your strategy then?
Yeah. Like for every other restenotic lesion, especially in the osteal circ, I think imaging is the key because we need to do OCT to understand the mechanism and then plan strategy based on the mechanism which led to restenosis. If it's just proliferation, then it's relatively simple because you can go with drug-eluting balloon, and we have, I think, enough published evidence about the efficacy of drug-eluting balloon for restenosis. But if it's neoatherosclerosis, and if we have also a plaque inside the ostium of the LAD, I think we need to change strategy according to that one and probably restent, use new stent.
Thank you. Another question on severe lesion in the ostium of a large diagonal of around 3 millimeter. LAD is around 3.5 to 4. Large diagonal with hostile angulation. Which technique would you recommend?
If I understand correctly, is it 001, ostial diagonal lesion?
That's right, yes.
So there is again no general consensus for any 001, but diagonal is slightly different from ostial circ, and in that case we have some of the published evidence, usually starting with lesion preparation with cutting or scoring, and then drug-eluting balloon in order to try not to implant stent. Because of the angulation, it's very difficult to implant stent exclusively inside diagonal. So strategy that we try to recommend in case of really large diagonal diffuse disease is inverted provisional, stenting from the LAD into diagonal, proximal optimization strat opening in the LAD, and then kissing. And I believe in case of some plaque, which is usually by imaging found almost in all instances of 001, it's safer and more predictable to stent directly from the LAD into diagonal than to try to cover diagonal and not being precise, so you have to put a second stent.
Another question about TAP. What are your thoughts on doing a kissing balloon inflation prior to the second stent in TAP, the pre-TAP KBI?
Pre-TAP means before putting the second stent.
Before putting the second stent,
Yeah.
kissing balloon inflation before that.
So I agree, because TAP is actually extension to provisional. And in case you are planning to put a second stent, you need to achieve optimal anatomy inside the bifurcation. And the advantage of doing kissing is that two balloons which overlap proximally oppose better stent in the proximal part of the main vessel. But the advantage is that by simultaneous inflation, you also put carina in the center. And having carina in the center is one of the major theoretical advantages of kissing compared to pot side pot.
Yeah, that was fantastic. There's another question on access and guide size. Two-stent strategy with 6 French guide. Would you go radial? Would you go femoral? Question of access.
Access for most of bifurcations, except for left main, with really large vessels that we need large non-compliant balloons for kissing, is 6 French radial. You can use, of course, also sheetless catheters, 7 French inside. If you are radialist, I think radial is excellent approach for 99% of the lesions nowadays. So I don't think there is any longer issue femoral or radial if you are planning bifurcation PCI.
Thank you. And there's a question on the chat, the perennial question of proximal stent strut crossing in distal in DK crush. Why is it different in case of DK crush? An explanation, please.
Yeah, thank you. Also, that's another thing that is really important to understand three-dimensionally, because when you implant stent in the side branch and when you inflate your balloon in the main vessel, you are actually pushing stent from the carina region. And by pushing and compressing stent against the vessel wall in the main vessel, you already have some small gap and not fully covered malapose struts at the carina level. If you are trying to cross distally, like you do in every other technique except for crush, in that case, you may risk to go with your wire inside that gap. And by going with balloon, you increase actually the gap. So I think the safest is to try to go central proximal. In case of visualization, it's extremely important to find before the procedure angulation which really best opens bifurcation angle, so you can really have clear view if you are going centrally or you are going distally.
Specifically,
last few questions. So sorry, Aisha, go ahead. Go ahead.
There was just a question about the access and taking 2 stents together with the 6 French. I think that was explained with the sheetless, recurring question, yes, rather. Yeah.
Exactly.
Thank you. Thanks.
Goran, a couple of final questions that always come up. I saw them earlier in the chat, and the fellows always ask me too, is when you do the pot, how do you decide where to put your balloon? Do you use the markers, the shoulder of the balloon? Balloons are different. Yeah. Some advice for the fellows, please.
Yeah. Yeah, if you go to PCR online, there is my tools and techniques section, and with my fellows, Dr. Mehmet Begovic and Dr. Jelic, we made nice video animations. So I really would like you to go and check if it's acceptable for you. What is important is to understand first a relationship between the distal marker and the shoulders of the balloons that you have on your shelf. And in everyday practice, again, we try to identify angle in which we really open bifurcation to make sure that balloon position is really correct and we don't compress carina. And then we try to position a distal marker just in front of the carina, if it's possible. And that position allows with shoulders to push also some metal into the side branch and open cells towards the side branch. So wide angle, which opens bifurcation the most, and then you position distal marker just in front of carina in that view.
Great. One last question for you and one for Antonia. One of the things, you know, me and you have been doing the jailed wire technique for years, right? There's still two things that really worry the fellows when I talk to them about jailed wire technique. The one is how to not damage the stent when you put in the gel wire. So maybe very quickly, just repeat your tips and tricks. And have you ever had an issue where you couldn't remove the gel wire?
Yeah. Thanks for that question. So what we try to do is first, if lesion is really calcific with large plaque burden, not to perform pots at very high pressure. That can create a risk of damaging the wire and difficulty to pulling out. But what you should regularly do is to disengage the guiding catheter, hold it with your left hand, and then I put torque at the end of the jailed wire, and I slowly try to push, visualizing the whole length of the wire plus the ostium of coronary artery in which that wire is positioned. If you have difficulty, don't forcefully push and insist. You can go with small over-the-wire balloon or microcatheter. Corsair is extremely useful. Over the jailed wire, and with Corsair you can go behind and relieve some of the tension, trying to disengage and to again pull back the wire. So far we did not have in our lab problems. We had some of the cases presented at the EBC, but in most of the cases what we learn is to be patient, to go step by step, and if you cannot simply pull it out, go with balloon. If it doesn't work, you can go with microcatheter, you can go with Tornus or Corsair. And I also saw if you have laser, there was a case report with laser, maybe with shock wave, you can try to break some of the plaque, calcific plaque behind the stent struts, and that will let you disengage and pull out your wire. Okay.
Antonio, a question for you. Hang on, you're still muted. Can you unmute? There you go. I can hear you now. Last question for you, Antonio. Again, one of the things I think that people struggle with bifurcation sometimes, that's a little bit concerning, is when you have a very challenging angulated side branch to wire, and it's difficult to wire. Maybe some of your tips and tricks that you've learned over the years of what's your algorithm when you have a difficult side branch that's difficult to wire, the wires you use, and then other techniques maybe that you will use if you have to.
This is a good question. I think I use a relatively, not a stiff wire, but not a very soft wire. I still use like a Miracle 3 or an intermediate, which is very steerable to go over the side branch. And in some, if you have a special catheter, you can use angulated catheter, but these are not widely available. And in some situations, in some rare situations, I may use a Gaia to create a path. But most of the time, I would say that with a relatively stiff wire, I can negotiate and go through the side branch. So Miracle. One point regarding the engaged wire, when you do two-stent and you trap a wire, as Goran said, it's very important to be careful about the guiding catheter, not to damage the left main with the guiding catheter. I heard and I had cases where the wire broke, and don't struggle to remove the piece of the wire. Just leave it there. It's not going to thrombose. I left many wires in the coronaries, and I heard more side effects and problems by struggles to remove the wire than leaving the wire inside. The wire inside don't thrombose, and most of the time, because they uncoil, they are not visible anymore, so you don't even have the bad aesthetical effect.
Great. And just talking, if you're unable to wire, you've tried all these fancy wires, Antonio, what do you do then? Do you do rotablation? Do you pre-dilate? Do you stop the procedure and say, so maybe I can't do this procedure?
It depends how big is the side branch. But if you are unable to wire, you should most probably do rotablation. You should do some, I do inflate the main branch, and most of the time I got lucky. But you know, it's a matter to be lucky. I don't like to do that. because you can occlude the side branch. So it's very painful. It's painful. I tell you, it's painful when you have a left main, a big circumflex, and you cannot dilate the circumflex. Make sure that you have some protection, but can be painful. I have no suggestion except prepare to be painful.
Great. That's I don't really want to stop with that comment about painful, but I think it highlights how complex our job can be at times. And it's nice to be able to smile about it now. Antonio, thank you so much for your comments as usual. Aisha for moderating. Goran, we can't thank you enough. This was really educational. And to the colleagues, we have another talk on Thursday with Dr. Garbo for tips and tricks in rotablation and rotational atherectomy. Dr. Garbo is very experienced, and I think you'll enjoy the talk. Thank you for joining us.
Thank you for invitation, Azim. Have a good day. Bye-bye.
You too. Okay. Bye-bye. Bye, Antonio. Bye-bye, Aisha. Goodbye, everybody.
Bye.
Thank you.